I give again an analogy to my patients saying, you understand arthritis, which is your joints are inflamed. It's the same exact thing with hepatitis. Your liver is inflamed. In this case, it's because of fat. And that fat, over time, because of the inflammation, end up getting scar tissue. Medical term for scar tissue is fibrosis. So as there is more and more scarring, you go from no scarring to minimal scarring to moderate scarring to advanced scarring, and eventually you end up at the last stage, which is stage 4 scarring, which is what is known as cirrhosis.
Joining me today is Dr. Apurva Modi. Dr. Apurva Modi and I go a long way. We actually started our medical school journey together, and we've been very, very good friends since then. Dr. Modi specializes in alcoholic and non-alcoholic fatty liver disease, viral and cholestatic hepatitis, and liver transplantation. He's board certified in gastroenterology and transplant hepatology. Dr. Modi completed a transplant hepatology fellowship at the University of Maryland Medical Center in Baltimore before joining as a liver consultant of Texas. His professional interests include management of cirrhosis and also working on programs to decrease hospitalization rates for patients with liver disease. One of his biggest passion is educating physicians, trainees, and even the community to be more aware of liver disease and the appropriate management options. Dr. Modi has been named a Texas Super Doctor for 2023 by Texas Monthly. Dr. Modi, welcome and thank you so much for joining me today.
Thank you, Arasi. Dr. Maran, like she said, we have been friends a long, long time. So I'm very happy to be on this podcast to talk about liver disease and just basically educate, like we talked about, in terms of what happens in patients with liver disease, because most of these patients are asymptomatic, and by the time they find out that they actually have liver disease, they're in big time trouble. So yeah, I'll be happy to answer any questions that Dr. Maran poses to me about liver disease. Right.
And since Modi and I go a long way back, it's going to be very difficult for us to keep this formal. So he's going to be Modi, which is how I've always called him all through my life. I've known him, and he's going to call me Arasi. So Modi, let's start. You kind of touched up a little bit on this when you were giving an introduction, that liver disease is so difficult to find out. And by the time they found out, they are full-blown jaundiced, etc. Can you first talk about the early signs of liver disease, especially the non-alcoholic fatty liver kind of a thing?
See, that's a really interesting question you pose, because just like in your field in cardiology, by the time patients find out they actually have a heart disease, they are symptomatic. They have chest pain. They go to the ER, and then you do all these things on them to basically treat the cardiac disease. The same exact issue we have with liver disease, because most people with liver disease, in fact, the numbers are only 30% or lesser of number of patients who have liver disease are actually symptomatic. So they don't find out until they either end up in the hospital with complications of cirrhosis, which I'll be happy to discuss in detail, or it's more they go to the primary care doctors for an annual checkup. Maybe the liver enzymes were slightly elevated, so the doctor does an ultrasound, and the ultrasound shows a fatty liver. Or very rarely, like I said, 30% or lower have some symptoms, which is very non-specific right upper quadrant pain, and they're like, oh, I've been having this pain for a while. They think it's the gallbladder, because as we all know, the gallbladder sits right under the liver. They get an ultrasound, lo and behold, now they have been diagnosed with fatty liver. So it's a huge
right upper quadrant pain. You mean the right side upper, just beneath the rib margin? That might be the first sign. Let's take a one step even before that. At what age do you think patients should even get their first liver function test done?
So, Arasi, I'm glad you're asking all these interesting questions, because I actually use this for my patients when I see them for fatty liver disease. And I'll talk about the most common causes of liver disease, but let's talk about fatty liver. I always give them a trivia. I'm like, what do you think is the youngest patient I've seen with fatty liver disease induced cirrhosis, which is end stage liver disease? And they're like, oh, let me guess, maybe 30, maybe 40. I'm like, no. I tell them I'm an adult hepatologist, so I only see adults, so basically 18 and above. My youngest patient who ended up having fatty liver induced end stage liver disease was 18. And I use the term was because he's no more there. He had such complications that he actually died from cirrhosis from fatty liver disease. So to answer your question, at any age, Yes, typically it's a chronic liver disease. I give the analogy of diabetes, is that it's a long-term, slow, progressive disease, 30, 40 years, but you can see it at any age group from 18 all the way to 80, 85, 90, or, under their lives. So, yeah.
So the whole spectrum is we start at fatty liver and then we end at cirrhosis, liver failure. That's the
Correct.
whole spectrum.
Correct. So you start out with what we call hepatic steatosis, which is basically fat in your liver. And that typically the risk factors for fatty liver are the risk factors that we're all aware of: metabolic syndrome. I'm using medical terms, but I will, of course, explain it with
Please do.
medical terms, which is if you have a waist circumference more than normal, and of course, if you have blood pressure and or diabetes, or if you have high cholesterol, all those are risk factors for having fatty liver. But what people forget most, I know we are talking about non-alcoholic fatty liver, but the most common reason for having a fatty liver on an ultrasound is alcohol, even today. In fact, it still outperforms non-alcoholic fatty liver, and especially COVID did not help because people sat in their homes and drank so much alcohol that we still have that big problem. But put that aside. I mean, that's a different disease, alcoholic fatty liver. Even just talk about non-alcoholic fatty liver, like we were saying, it's still, those are the risk factors that lead you. So you start out with just having simple steatosis, which is just some fat getting into your liver. The fat then causes, over time, accumulates, causes inflammation, inflammation anywhere in the body. And again, to people, when I use the word hepatitis, which is liver inflammation, hep is liver, itis is inflammation, people automatically think, oh my God, I'm contagious. I am going to give this to somebody else. It's such a stigma associated with it. So I give again an analogy to my patients saying, you understand arthritis, which is your joints are inflamed. It's the same exact thing with hepatitis. Your liver is inflamed. And in this case, it's because of fat. And that fat, over time, because of the inflammation, you end up getting scar tissue. Scar tissue is what we worry about in the liver world. The medical term for scar tissue is fibrosis. So as there is more and more scarring, you go from no scarring to minimal scarring to moderate scarring to advanced scarring, and eventually you end up at the last stage, which is stage 4 scarring, which is what is known as cirrhosis. And once you're at cirrhosis is when you get into trouble.
So we'll talk about cirrhosis and end stage liver disease in the later part of this podcast. Let's talk about the fatty liver. And I want to focus on fatty liver because, as you know already, and you will educate me a little bit more, it's a reversible issue, right? So let's talk about fatty liver. And is it just a blood test? Is that the only way to diagnose fatty liver, or how do we go about that?
Great questions, Arasi. So, and I keep saying this because, people think that, okay, why wasn't I diagnosed with fatty liver? I've been seeing my primary care religiously for 20 years. How come he or she didn't tell me that I have fatty liver? And I tell them the problem is that, first of all, like I just mentioned earlier, that most people are asymptomatic, so they never felt it. They don't go to the doctors complaining of pain. Okay, if you're lucky, I would say lucky in a really sarcastic way, because if you're lucky that you have pain, you get diagnosed earlier. But let's say you're not one of the 30% who have symptoms, then you just go to the doctor, then you do annual blood work. Again, if you're lucky, your liver test might be abnormal. And the doctor's like, this liver tests are not normal. Let's do some further workup. But many people with fatty liver have completely normal liver tests. And that's the issue. So that's why there's a lot of push now, of course, among diabetics, because one thing that is not very well known is that 60 to 70% of all patients with diabetes have fatty liver. So there is a push with the American Endocrinology Association to do an ultrasound, basic ultrasound, on anybody who has diabetes. In that way, you can catch fatty liver way in advance. And once you do that, then you can educate the patients. Initially, all you need is lifestyle changes. And we have this big long discussion about weight loss. And what I tell my patients, recommend my patients, is lose 1 to 2 pounds a week. It's not every day, 1 or 2 pounds a week. And we really highly recommend the Mediterranean diet, only because it's evidence based. It's not that the other diets may not work. The thing I like about the Mediterranean diet is that I don't call it a diet, I call it a lifestyle change. The reason I call it that is, unlike your Atkins and your keto diet, which is really hard to do long term, Mediterranean lifestyle is something you can do long term, because you basically make those changes of eating a low carb, low fat, high protein diet. There's a lot of things in the Mediterranean diet where you'll be like, oh, I didn't know I could, eat my chicken, my seafood, my, all my nuts and legumes and fresh fruits and vegetables, and it's all there. So I tell patients, look into that, try to put that, as a change in your what you do in a weekly basis for your menu. And then a lot of patients who follow religiously actually lose a lot of weight. So that's
And
the first thing.
and it reverses the fatty liver.
Absolutely. So if you are not at the stage of cirrhosis, like you said, we're not going to talk about the end stage liver disease. You are at stage 0, 1, 2, 3, which is non-cirrhotic, non-end stage liver disease, not at the end. You have a chance that it will reverse itself because the fat, and again, I use analogy of saying, the fuel that's igniting the fire has been taken away. So if there's no fuel, the fire is going to stop on its own. So you take away the fat, the inflammation will recede, your chances of scar tissue will also go down. So it really, and studies have shown that if you at least lose 10% of your body weight, 10% is all you need, you're going to see that fat leaving the liver, you're going to see that inflammation going
It's so funny how we all have very similar analogies. I have this whole fuel and fire analogy also. So when I have a patient who keeps coming back with recurrent blockages in their blood vessels, and their blood sugars are super high, hemoglobin A1C more than 10, and I'm like, I'm the plumber of the heart. This house is on fire, and you're asking me to come and fix the pipes.
down.
And
That's right.
I'm coming into this house and I'm looking around, there's fire everywhere, but you're asking me to fix the plumbing. Yes, I can fix the plumbing, but unless you fix the fire, the house is not going to take it. The same way, the diabetes is such a fire. It's a forest fire. Even cancer sometimes, it starts in one place and then spreads over time. But
Yeah.
the day you get diagnosed with diabetes, every cell in your brain to the tip of your toe gets affected by that increased blood sugars, blood glucose levels, and I recently had a patient, 41-year-old, with an acute heart attack, with florid diabetes. And on the table, after we finished the procedure, he's like, "How did this happen to me?" There was so much anger in his face. And I'm like, are you really? In my mind, I was thinking, so nobody has talked to you that when you are diabetic, you're at a high risk for heart disease, and this could have, totally happened to you. I mean, I think that's the whole point of this podcast, to educate every person, healthy, non-healthy, patient, whatever, anyone who's interested in improving their health, about this. And that's why I feel like fatty liver gets so unnoticed. And so let's go to alcoholic fatty liver.
Yeah, just before that, Arasi, I want to bring a comment about what you just said. And you know this very well, but because you just brought up diabetes, is that now there are many, many, many studies that have shown, and we can put it up, that fatty liver is, in terms of, it doesn't matter what stage of fatty liver you're in, meaning if you have just minimal fatty liver to like all the way you have cirrhosis, which is end stage liver disease, you are at a high risk for cardiovascular complications. Just even without diabetes, I mean, as a risk, as fatty liver, as an independent risk factor for cardiovascular complications. So, we, even people who get transplants for fatty liver, which is now becoming the second most common cause, we're going to talk about the first, which is alcohol, is these people, unfortunately, they were so sick before a transplant, because once a liver fails, it's not, again, tell people this, you just one liver. Unlike two kidneys, you have one liver. There is no dialysis machine for the liver. So we take care of it, and if we can't, we transplant it. And those people who get a transplant, they feel so much better. So they start eating like nobody's business. They gain a ton of weight. And the next thing you know, now you have somebody who is post-transplant on immunosuppressive medications, basically anti-rejection medications, that has put on a ton of weight. Now, because of the anti-rejection medications, they have risk factors of high blood pressure and diabetes on its own. So you're adding so many different unfortunate things that can make your cardiovascular risk so much higher. So I tell them, I even give again a trivia to the question saying, what do you think is the cause of death after a transplant? They're like, oh, the liver failing. I'm like, no, sir, no, ma'am. It's your getting a heart attack. And you won't believe how many people we hear, oh, he had an MI and now, he had a stent or he died from this. Yeah. So it's a very important point you bring up, the whole relationship, fatty liver with all, every single kidney, of course, cardiovascular is like so associated.
So, we're going to digress briefly. Clearly, I know, I mean, everyone who's on the internet, the message is being screamed at, right? You are what you eat. Please eat better, blah, blah, blah. But despite that, why is it so difficult? What do you think are the barriers for us to eat better? I mean, us as you and I as adults, human beings, our teenage kids, for them to make better choices, and even people older than us, like people in their 50s and 60s, and what do you think are the barriers from choosing better?
Great question, Arasi. So the reason I say that is I can just let's just talk about myself, right? I mean, forget about patients, forget about everybody else. I can, of course, the only person can who can introspect and see what's wrong or what's good with me is me, right? And so let's just my upbringing was in India, and we are from the western part of India, Gujarat. Even though we grew up in Chennai, we had this whole Gujarati lifestyle where everything we ate was filled with sugar. I mean, if you have ever tasted Gujarati food, it's basically sugar laced with everything. So even today, unfortunately, that's carried on. Where I every day when I go home or in the morning or whatever, I want to have something that's sweet, whether it's a piece of cake, whether it's a candy or whatever. So I want that. I mean, I'm craving that. So my body is so used to wanting that. So now just let's really make it. Now I'm health conscious. I work out a lot. I do everything that I can do, and I'm giving this information out in the podcast because I think the world should know this. In a good way. Is that I have also been diagnosed with fatty liver 20 years ago. Okay, and I made changes to my lifestyle because I'm like I'm not going the way that I see that I take care of my patients. So now think about those young children who are being basically brought up with junk food, what we call junk food, high, very
Ultra
sweetened
processed.
calorie, high fructose corn syrup foods. You give them that day in and day out. What do you think is going to happen to them when they become adults? They're going to crave that food and they want to keep eating that. So it is super hard for a patient who is already on that kind of a diet to make drastic changes. Yes, it does happen. My personal trainer made it happen for himself, and now he's like, very, very, very healthy. But that is, I can tell you that by taking care of patients with fatty liver, it's like less than 1% of the population who has that drive to say, I'm going to change my life around. I will not allow this to happen to me. But most people, the first comment they make when I talk about Mediterranean lifestyle or losing weight is, Dr. Modi, I have tried this so many times, I just cannot do it. That's like the typical answer I get because the body is craving it. So your crave
Brain.
center in your brain is like, I want this. Give me more of this. Give me more of this. And it's very hard. It's just really hard.
It's very like Modi. Thank you for sharing your personal story, and you know my personal story as well, right? I have a very strong family history of diabetes, and when I was 40, when I just turned 40, I did my blood work, and my hemoglobin A1C was like 5.8, and I freaked out. I was like, oh my god, I'm almost pre-diabetic. I'm like high risk, and I turned my life around, and I tried the only and my problem is sugar as well. I truly have a chocolate addiction. You know that very well. And the struggle is real, the fight is real, but there are ways to overcome it. And I kind of, what do I say? I refuse to believe only a small percentage of the population can do it. I want all of us to fight it. We can't change what happened to us in the past, but we do have control of what we can do to ourselves right now and going forward. And I think that's why all of this is happening. What do you
But a
think
big
about the
point,
drugs?
but a big point I want to make, Karasi, is that remember we have to keep in mind the socioeconomic status of a person.
Yes.
That is the problem. So we see that fatty liver affects the people, and there's many studies on this too. The lower your socioeconomic status, the worse the liver disease, overall, in terms of getting more liver disease. So when you go to a Burger King or McDonald's or any fast food restaurant, I'm not going to name one, when you can get something for $2 for a lunch meal versus going to a health food store and try to get something which is like $10, $15, what do you think a person, who makes a basic wage salary is going to do? That is where the problem is. What do you think our vending machines and our children's
Hospitals.
schools are
Yeah.
providing? I mean, we give food to our kids. My wife makes sure that they get their lunch packed, but it doesn't happen in our households. They go there, they get whatever, which is basically pizza, some kind of a snack, and some kind of a soda. That's typically what they get for food. So if you keep in mind the socioeconomic status, it's really difficult to overcome that. You can say, yes, I have a big drive. I'm going to do this. All great, but in the end, it comes down to your financial status. How much can you afford? Is it possible to go to Whole Foods and buy stuff, or am I just going to go quickly to something fast food and get my food?
It almost feels like majority of the population are caught in this web, right? They work two jobs, they might be a single parent, they're trying to juggle life and kids and work and make ends meet, and they obviously are going to do whatever they can to just get through that day, get through that week, and the choices available are so poor, it almost feels like the system is working against all of us, right? The system is almost designed to make the general population fail, and then the vicious cycle keeps going on and on and on. kind of one of the positive things which came out recently is the weight loss medications, and now Medicare and Medicaid has approved the Ozempic and those all those group of drugs for weight loss. How does that affect, apart from weight loss, does it have a direct effect on the healing of the liver itself?
So yeah, it's I'm a little what should I say, split in what I think about these weight loss medications. That I love that we have something to treat obesity, but the problem is anything that you take long term, is going to have side effects. I mean, we just don't
Oh
know that
yeah.
yet. We don't have long term studies. Yes, all these medications were approved for diabetes, and they saw it as a side effect, which is weight loss, which is why they eventually got approved as weight loss medications. We're all familiar with medications out there, that we have Ozempic, Mounjaro kind of class of drugs, and people are using it. As we very well know, these pharmaceutical companies that have these medications are doing super well because everybody
Oh
wants weight
yeah.
loss medications. But number one is that how long are you going to be on it? What happens when you get off it? That is the big question. Are you going to be on this medication for the next 10 years? What happens? Did you change your lifestyle while you were on this medication? Because I believe that if there is a patient or who are willing to change their lifestyle and then go on weight loss medications, that's a perfect combination. Because now when they get off it, they're going to be on that good lifestyle, which is going to, really allow them to sail through all their health problems. But if you are just going to be, I'm going to just take a pill to make this better for me, or take a shot, which is what these medications are, it's not going to make a difference once you stop it. You will gain the weight back because your body's going to say, I want to go back to that metabolic state that I was in. Okay, this was not okay for me. So let's now get back to it. So I'm going to eat more. And this is what we see in my patient population once they get off medications. So yes,
Absolutely.
great, but unfortunately not there yet.
So, I mean, this medication from the heart side, there's obviously studies are already out there. It reduces the risk of heart disease and even heart failure, diastolic heart failure, which is when the heart gets too stiff. It's all great, but as you said, if you don't change your brain and you don't change the reason why you eat, and for me, it's stress. So I had to like literally find fidget spinners and sparkling water instead of chocolate. And even then, there are moments I fail. So you have to you have to figure out what's your why. Why do you eat? Why do you crave certain types of food, and then fix on it? But it's a lot of work, and it's a lot of work. It is
Uh,
time consuming, and but we have to make it easy. We have to make it. We have to keep shouting at the top of our voices. Whoever can get the message should be able to take it on. And there's a lot of help right now, at least, and I hope they are able to find the help they need. So we talked about fatty liver, non-alcoholic fatty liver. Let's switch gears and go to alcoholic fatty liver. Now, tell me about that.
So, Arasi, before we move on to alcoholic, this one very quick statement I want to make is that, I'm not a naysayer. I'm not talking about the doomsday. Okay, that's not me. I'm an optimist, and in fact, a realist more than an optimist. And I just want to put it out to the crowd out there who will be listening or will listen to this is that there is actually a newer medication, not just weight loss medications. That is the first FDA approved medication to treat fatty liver. Okay, and it just got approved a few weeks ago. It does not work the way we have these weight loss medications work. It works in a complete different mechanism of action. It works on the thyroid receptors, and it makes you, of course, decrease your fat in the liver, but also decrease inflammation, decrease fibrosis. Yes, the response rate is not amazing. I mean, it's 1 in 4 people will respond to it, but at least we have something for people who have advanced scarring and they are doing everything, but they're already there, and we can at least bring them down by one stage, make improvement in the amount of scar in the liver. So it's not all bad yet. This is just the start. We're going to have a lot of medications for fatty liver. So, yes, work on your lifestyle because that is the key thing, but there are medications to help you out too once you reach the stage where you think there's a point of no return. Okay.
So
Yeah.
it's not. What is the name of the medication, Modi?
So the molecule is called resmetirom, is what it's called, and it's the actual medication is called Redzifra. It's a really odd name. I don't know. I guess somebody said that more disease in the medication they sell better or whatever, some kind of thing. But that's what it's called. It just came out. We have still not
Yes,
started
I
prescribing
saw
it,
that.
but we are learning about it as we go. But yes, let's talk about alcoholic liver disease. Unless you have a question.
I have a question
Yeah,
actually. You said so. It's not for stage one fatty liver. It's for stage three,
2 and 3.
2 and 3.
So it's
Okay.
not yet approved for stage 4, which is
Mhm.
your end stage liver disease, which is your cirrhosis. But it will get approved for that hopefully at some point because there are studies that are ongoing. But it's for really the moderate and the
Middle.
advanced scarring in between because they're the ones who are the chance of further progression and end up in trouble, which is what we don't want.
So let me see if I can segue. It has no role in alcoholic fatty liver at all.
Not been studied. It will be. There is a unfortunately alcoholic liver diseases simple, but it's hard. In that those patients, yeah, because there is a whole set of liver disease, and we're talking about alcohol, which is a big deal. We need to talk about it.
Yes.
Is there's a term called alcoholic hepatitis, okay, acute alcoholic hepatitis, which is very different than the chronic progressive damage you see in the liver with fatty liver or with hepatitis C or with hepatitis B. Because these are patients who are typically young, can be older too, but typically young, who binge drink. They think that, as we all young people think, that we are invincible, right? So they drink a lot, and then they've been drinking just for a couple of months, but drinking really heavily. And they get this thing where there is an acute alcohol damage to their acute inflammation to the liver. I again use an analogy of a lightning strike to the liver. It's like lightning strike to your house, but lightning strike to the liver. It just really shuts the liver down immediately. And the next thing you know, you're in acute liver failure despite not having a lot of scarring in your liver. Okay. So that's one liver disease we see so frequently. And because there's such a big pro-inflammatory state, meaning so much inflammation going on in your liver, that none of these medications that you're talking about, the new medication of fatty liver or, of the weight loss medication, none of them are going to work because it's the alcohol which causes severe inflammation, right? And those people, by the time they come to us, because it just happens so quickly, they have a 50-50 chance of making it. I have to have these difficult conversations with families. These are young people. I'm talking about 20s and 25, 30s, young parents or not married or whatever. It's like, I'm talking to the parents, I'm talking to the spouse because the patient is so sick, they might not be able to have a conversation with me. They're like, I don't know, but there's a 50-50 chance at this point. Like, what do you mean? I'm like, there's a 50-50 chance of making it, survival or not. And they're like shocked when they hear that. So alcoholic liver disease is a beast. Now, of course, we have the second type of alcoholic liver disease, which is alcoholic cirrhosis, which is a slow, progressive 30, 40-year damage. They start young, by the time they're 50, 60, they end up with damage from that. Yeah, sorry.
I want to still go back to the acute alcoholic liver disease. I
Yes.
just have a couple of questions. Do we have a set amount? Like, do we know a person who weighs 140 pounds drinks 5 drinks? I mean, is there like a set amount of, or a correlation between the amount of alcohol and the person's BMI or anything like that?
Yeah, it's a very good question again, Arasi. And the reason I say this is, all the stuff we have is based on the general Caucasian population in the United States. Okay. So when we give out what is so-called more than moderate alcohol use is more than 3 drinks, 3 8-ounce drinks for a man versus more than 2 8-ounce drinks for a woman per day, daily, right? Now, what you just asked me is a very important question because the Asian population, Vietnamese, Indians, Koreans are much smaller people. So that 2 and 3 drinks that we just talked about is probably too much for that population, and we don't have that. So in fact, it's in the guidelines for the Asian population. It's literally 1 drink lesser. So it's more than 1 drink, for a woman, and more than 2 drinks for a man. So it's there. Now we don't have large studies to show that okay, if you drink in that what is so-called okay for an Asian, for somebody who is smaller, like you said, 140 pounds, are you going to be okay from an alcoholic hepatitis standpoint? Because remember, alcohol requires an enzyme for metabolism, which is in your liver. It's called alcohol dehydrogenase. And from our medical student days, we remember they have the strong and the weak inducers of that enzyme. So there are some people who are just lucky. They drink like a horse their entire life and they don't get in trouble. And there are people who drink a little bit and they get in trouble. So a genetic role, of course, a race role, and of course your BMI, all of them, and of course, most important, how much you drink, plays a role in if you are that candidate for getting acute alcoholic hepatitis, which is devastating. I mean, we unfortunately see a lot of that, and there is no medications for it. Everything that's been researched has never actually panned out in terms of treatment.
That's honestly very scary because, I still remember when I had kids and when you had kids, I made sure my kids had no exposure to soda till they went to middle school. The moment they went to middle school, all floodgates got open. They start making their own decision, and now we protect them in the house. Or I mean, honestly, I'm tried my best not to be a super tiger mom, but I am a tiger mom in my son's standards. But when you're talking about this, my oldest will be in college in 3 years, and my heart rate is going up a little bit thinking about it because then he has to go and make his own decisions, and of course children don't like to listen to their parents, and it doesn't matter who their parents are. Okay, so there's no treatment, and what are the options? You wait for the liver to heal, or
Yeah, yes. Yeah, absolutely. So, there are some studies looking at using an anti-inflammatory prednisone, very common drug. General population knows it. Unfortunately, the response rate, meaning will it work or not, is really, you throw a coin and it's really,
It's a,
you don't know, flip of a coin. You don't really know are you going to respond or not. We use it in those really sick people who come in so yellow. I mean, they're literally like sunflowers, and we put it in them because they're getting worse over time. There's nothing else for us to offer. It's too late to stay off the alcohol. Of course, they've been off the alcohol because they're in the hospital, but there's nothing else we can provide to them. So, and then there are certain subset of patients who can actually get a liver transplant, even despite having had to drinking alcohol until a couple of weeks before their hospitalization. But for the general population, this is a really important message. Typically, in 98 to 99% of patients in that state, they are not going to be transplant candidates because we have a 6-month abstinence of alcohol rule in place, which is in most transplant centers where you have to be 6 months alcohol free for you to get a transplant. Why? They're like, I tell them that, and everybody understands it, is that if you get this alcohol and you decide that after, the liver transplant, and after the liver transplant, you decide to go back to your old ways of drinking, you're going to destroy that new liver too. And this could have gone to a patient who needed it. So I'm not going to use the word deserve because I don't think it's right that you say deserve or not, but really somebody who needs it more than you got it and you destroyed it. So yes, transplant is an option, but you have to meet really strict criteria to be able to get a liver transplant in that time period before the 6 months sets, creeps in. Is that I can tell you that in 2023 in our transplant center, we did about 120 to 140 liver transplants. Only 2 of them were for alcoholic hepatitis.
oh, wow.
Okay. Despite majority of them, at least 50 to 60 probably is for alcoholic liver disease. 2 out of those were just for acute alcoholic hepatitis. So not a common thing. I wouldn't use that as a strategy to say, I'm going to drink, transplant will save me, because you may
No,
not be a candidate.
no.
Yeah,
And teenagers do not get this message at all. They don't hear
they
it.
don't.
They probably see my podcast and swipe me because they're not in their age group. And, oh God. Okay. It's very scary. Very scary. Now let's move on to the chronic alcohol problem, which affects, the problem starts pretty much in early college, age of 21, and keeps going on. More and more studies are coming out that no amount of alcohol is safe. The cardiac thing that has gone back, where moderate alcohol was good for the heart, to no amount of alcohol is good for the heart or the brain. How is it for the liver?
Yeah. So just a little bit I want to provide to the audience here is that, the Mediterranean lifestyle diet, if you look in the details of the diet, it actually allows for alcohol use, one drink of, wine or whatever, because, it's a Mediterranean, everybody drinks wine there. But I tell my patients that that's the one thing you don't want to follow, because there are people who have a combination of both diseases. It's not like the liver says, I already diseased one, now allow something else. I mean, we have so many people wherein, when I see them, I'm basically telling them you have alcoholic plus, non-alcoholic fatty liver disease. I mean, they're not, using that term because they have both together causing liver damage. And again, in the liver world, 1 plus 1 is not 2, 1 plus 1 is 11. So if you have one disease and then you are adding a second thing to it, you are causing damage much quicker than what the 30, 40 years that I mentioned, you're talking about in 15, 20 years. So now let's say you are at that stage where you have cirrhosis from alcoholic liver disease. So you are there already. Again, what we talked about earlier, most people don't even know that they have liver disease. No symptoms, feel great. They're like, I've been doing great. I was drinking so much, but I was fine. That is exactly the problem. Is that this, and you won't believe it, Arasi. I have so many people who started drinking alcohol, like a lot, not just one drink, at the age of 12. I had somebody in my office who came with his fiance who started drinking at the age of 8. I was like, how did you even get access to alcohol at the age of 8? And the fiance was herself like surprised. Like, she's like, what? She looked at him and she's like, what? My point is very early, access to alcohol. Now you've already reached the stage, maybe at the age of 40s, 50s, where you have cirrhosis. Now you start having symptoms because your complications of cirrhosis, which is you start swelling up with fluid in your belly and your legs, sometimes in the lungs, so you come in the hospital short of breath, you're full of fluid, or you have a buildup of toxin called ammonia, which basically the liver filters, but it's not able to filter it. So now because it's damaged, so it goes to your brain, you come in confused, sometimes in a coma, you get on a breathing machine because you can't, keep your secretions. Or of course, you end up throwing up blood because you have all this pressure built up in your liver that's now being, backtracked into your blood vessels in your food pipe, which then burst because there's too much pressure. Or the worst thing that can also happen is you end up with liver cancer. So typically that's when people present, they're like, this has happened overnight. I started swelling up. And that's when they find out. And by that time, we're like, of course, stop drinking. Most people do. There's some people, unfortunately, even at that stage, it's an addiction. They can't. I very, very, now proactively offer, the medications for alcohol cravings. I wasn't doing it. As a group of hepatologists, we are not super good at it, but I've started the last year. I've been actively telling my patients, if you need something for your cravings when you stop drinking, I'll be happy to prescribe it for you to help you through this hard time. We tell them to go to Alcohol Anonymous. So we do all that while we are waiting for the 6-month rule. Every patient who was diagnosed with cirrhosis, end-stage liver disease from alcohol has to wait 6 months. They are not candidates for getting a transplant earlier because this is typically something they knew, but they didn't stop. The primary care doctors might have told them, you really stop drinking, your liver numbers are slightly up. They didn't do it, and now they have ended up with end-stage liver disease. So we wait for the 6 months and hope they make it there. The good news is alcohol is a very forgiving disease, meaning alcoholic liver disease, meaning 2/3 of people, even with alcoholic cirrhosis, when they stop drinking, the liver actually calms down. Again, the same concept of fuel and fire. Fuel is taken away, fire stops burning. The liver actually starts getting better. It may not, the scarring might not completely go away, will not, but it gets better enough to not cause trouble, and they don't require a transplant. Only 1/3, there's just so much damage that it's a little bit too late. They're the ones that we wait for 6 months to talk about a liver transplant. So it's not not a doomsday thing. Oh my God, there's nothing you can do. They feel really happy when we tell them this, that you have a chance, just work on it, do the right things, and there's a high chance that you might do okay.
So, apart from, as you said, ascites, which is when the fluid builds up in your belly, or the swelling in your leg and the difficulty breathing. Earlier, I mean, is it back to how we were at fatty liver? There's not much things happening sooner. You can pick up, sometimes, when I see someone who's been drinking a lot, I kind of see the face is a little puffier than the other person. The eyes are always bloodshot. I mean, what do you think about those signs?
People can really conceal the amount of alcohol used really well, Arasi. I mean, you can have that kind of patient, a good little bit of makeup will change everything. I mean, it's hard to really diagnose somebody by looking at them unless they're floridly jaundiced, meaning they're yellow by the time it's too late. It's really hard to know that. But I'm going to ask you a question. I know you've been asking me questions. What do you think is the most common symptom in anybody with liver disease? The most common?
Pain, which is
No, it's fatigue.
It's
fatigue.
Fatigue.
Are you and I not fatigued at the end of the day? Everybody is fatigued at the end of the day.
I mean, fatigue is so.
That is the problem. Every patient who walks into my liver clinic, the ones when I ask them, I go through the whole history, I'm like, okay, so what's the symptom? Oh, I'm always tired. And I'm like, how can I use that as a symptom to really screen out patients or screen patients for liver disease? It's universal fatigue. They don't even, by the time they start itching or whatever, it's a little too late. By the time they have all these complications that you just talked about, too late. And that's the problem with liver disease. You don't have symptoms. By the time you get symptoms, you're in trouble.
It's almost like nature's protective mechanism of the liver's resilience works against us because it doesn't show up. It's not a squeaky wheel. It's not squeaking earlier on. That
very, very true. And you'll be surprised at the unfortunate amount of, I would say, just lack of education. Hepatology is not a field by itself, just so that everybody knows. There's only transplant hepatology, so liver transplant is a field by itself, which is what I do. But hepatology is a part of gastroenterology training. Even in training, you get 3 to 4 months, 5 months, maybe maximum, and 3 years of training for liver disease. And it's so much more complex than gastroenterology. They don't get the training. So even gastroenterologists, they unfortunately may not do a great job of educating people in terms of liver disease. And then what do you expect from primary cares? So there's such a lack of education that that's like my goal, is to see what I can do to just bring this, to the community, of course, to the doctors, but the community saying, this is what you need to look at. Okay, don't just go by symptoms because you will have none in most cases. Don't just go by liver test being high because you may have completely normal liver tests. But these are things you want to look at. Do an ultrasound, do basic stuff to figure out if you have a problem with the liver.
What is the screening process? Like from breast cancer, we do mammograms, etc. Is there like a screening process for liver disease which we can do?
None, Arasi, none. There is no screening for liver disease, period. That is, even only time you get screened is when you're trying to get life insurance. You get liver test checked. Even then, you could have normal liver numbers.
Yeah.
If you're unfortunate and you end up having high liver numbers, you won't get life insurance. They'll give you a very small amount. That happened to me. They denied me life insurance, because my numbers were high. So the point is, it doesn't, it is no screening test. The ultrasound is a decent test. Unfortunately, as we all know, it's a flawed imaging technique, but at least simple to do. Instead of sending somebody for an MRI, CAT scan, ultrasound is simple to do. You can do that, and you can at least see there's something going on in the liver. Does it show a little bit of fat? I mean, is the liver larger than normal? Which you won't feel. Yeah, is it showing an enlarged liver? That would at least start the workup for saying, let's do it. Now, you have screening tests for viral hepatitis, your hepatitis B and hepatitis C. That is universal screening for all people in the US for hepatitis B and C. But there's no way of screening for alcoholic liver disease and non-alcoholic liver disease. There's just none, except
That
maybe the
is that
ultrasound.
is
Go from there.
so. What about the fibrous ultrasound scan to check the amount of fibrous tissue within the liver? Is that
Correct.
not a screening test?
No, so it's a fiber scan that you just mentioned. The fiber scan is to basically evaluate the amount of fibrosis scarring your liver, but that is not done as a screening by primary cares. It is done after the patient walks into my office or a gastroenterologist's office, and it's a $85,000 or $100,000 machine. People are not able to afford getting it. In fact, I just met somebody from UCSF, who just got a fiber scan machine a few years ago, even though technology has been 10 years or more old because it was so expensive. Imagine. So if you're talking about a big institution like that having a difficult time getting it, we have had it for a long time. It is not out there for as a screening mechanism. People are not, we use it, but it's not for the primary cares and community.
Ah, that is, pretty heartbreaking that we have one liver. It does everything which we eat goes through that liver, and
Right.
we don't have enough tools to take care of it better, or at least diagnose the problem better. Uh, we have to switch gears now again. Let's talk about supplements. There are
Yes.
so many advertisements. Oh, this liver supplement, this cleanses your liver, this detoxes your liver. Is there a thing called detoxing the liver?
I it's so again it's a little difficult for me to answer this question. I'll tell you why. Because I come from India, as we both do, and I believe in Eastern medicine. So we have our subgroups of medicine in India, the Ayurvedic and homeopathic, medicine, which clearly has its limitations, but also has a good role in preventing chronic diseases. So unfortunately, what's happened is that when people take all these cleanses, liver this, liver that, there's so many out there. We don't know what's in there. The ingredients, I use a basic rule of thumb. I tell my patients, if you cannot read the ingredients, don't know what they stand for, you shouldn't be taking them. Okay. Does that mean that those are bad for you? No. Okay. Do I have enough evidence to show that they are probably going to work? For example, there's a very common one that's now being, people can get it from anywhere, Walmart, Costco, whatever, ashwagandha. Okay. Ashwagandha is an root extract, and it is supposed to really do a lot of things. But unfortunately, ashwagandha, when taken the wrong amount of the amount you taken, can cause liver toxicity. Okay. So then I truly believe I'm actually a big complementary alternate medicine person. I try to tell patients what they can and cannot use, but I don't have the knowledge base. I don't have the knowledge to tell them this is what you should do. Go back to this practitioner in India. Maybe you should start using this. People still do it, but in the US itself, because we practice here, there is such a limited role of Eastern medicine. People take it from people who don't understand Ayurvedic or homeopathic medicine. Then they get in trouble and they come to us because now they had a liver failure. So there's one thing that I want to specifically mention. Milk thistle comes up all the time. A lot of people take milk thistle. There's been a ton of research of milk thistle and liver disease. Unfortunately, it's never shown to actually cause improvement. But what it has shown is that it does not cause any problems. So when people are on milk thistle, I tell them you don't need to stop it. But there's a big role of milk thistle in depression. And as you know, many of these people with liver disease have some psychiatric thing with like fatigue. They're like kind of a little bit depressed. So I'm like, it does increase your making you feel better overall. There are actual studies, published studies on milk thistle and depression. So if you want to take it for that, for the general sense of well-being, be my guest. But if you're going to be expecting that it's going to take care of my fatty liver without me changing my lifestyle, or take care of my alcoholic liver disease without stopping alcohol use, it's not going to happen. So I tell them this. So I'm not the person who can answer a question about other supplements because unfortunately I lack that knowledge. So I just use the basic thing. don't use it, until we have more information, or tell me what you're using and we can look it up and talk about it, kind of thing.
And this has become such a big industry, right? There's so many different companies, so many kind of, you just don't know what is in them, and they just come with the seals of this seal and that seal, and claim. The internet is filled with claims. My oldest son, he's like, oh, I want to take ashwagandha because he saw a YouTuber or someone showing big muscles because of ashwagandha. I'm like, no, where is this coming from? Who's manufacturing it? What is the dosage of it? Unless you tell me all of this, you're not even touching it. So it's the amount of information. We're not able to control the amount of information everyone's exposed to.
Right.
And that's why I'm so glad you said it the way we said it. This podcast is all about evidence-based science. What is the evidence we have and what is the evidence we don't have? And it might be a good thing, but right now, right here, we don't have the evidence for it. And that's all we can tell you at this time.
Absolutely. I mean, I completely agree with that statement. I think we have to go by evidence-based, because I cannot start talking to a patient and telling them what to do if it's not evidence-based. Of course, I can have it experience-based. I can have what we call the expert opinion, because sometimes we use that. But when it comes to supplements, it's very difficult for me to give them an expert opinion or even my own experience, because I don't have one. I don't have enough to tell them that. That's a problem.
Absolutely. So, Modi, I'm going to ask you this again. This may be something you are very familiar or not. What do you think about fasting and intermittent fasting? It's a habit used for centuries in our culture back in India. It's gained a lot of popularity. There's been positive press, negative press. It's been people love it, people hate it, people adopt it and change their life. I personally like it, and I use it in moderation. What is your thoughts about fasting?
Yes, again, great question, Arasi, because I tell my patients, and it's in my instructions, to really consider intermittent fasting. Okay. What we do know is this. I mean, when you take consume calories at a time when your body is not expending those calories, clearly in a body, and this is not me or you saying that this works on me and this has all this stuff on that. That's data saying that when you have all these calories that are building up, it's the body's converting that glucose into fat and storing it somewhere in your adipose tissue. Of course, when it's excess there, it's going to liver. I mean, and other organs, but liver is one of those susceptible organs. So we know that. So the whole concept about intermittent fasting is really to prevent the excess calories for X amount of hours in a day. And that number can be variable in various studies, but typically they say about 10, 12, 14, and the studies all over, right? I mean, so I very strongly believe in intermittent fasting more as a habit, more as really making it a discipline, that now you know that, okay, I'm not going to eat in this time. I'm not going to eat at wrong times before going to sleep or whatever. And I'm going to do this. And of course, if you get the calories, you're going to lose weight. I mean, it's just a consequence of the excess calories you take. So I strongly believe in it. And in fact, there is a lot of research on intermittent fasting. So nutrition and liver disease go hand in hand. I mean, it's a huge deal for us. Whether you are too thin or you're too obese, both are a problem. Okay, because those affect liver disease really badly. So when we talk about that, we talk about nutrition, we talk about intermittent fasting. I tell my patients, and there are studies, like I said, for the role of intermittent fasting and its positive effects on preventing steatosis, which is fat accumulation in your liver, and fibrosis because of a fatty liver. Okay, so it is there. I tell patients maybe you should stop eating after 5 p.m. if it's easier for you, until the next morning, 6 p.m. That's like almost 13 hours of fasting. That's really a good deal. Restrict yourself to a particular time of the day when you eat. Eat smaller meals. Don't eat very large meals. Throughout the day, pace your meals in that 8-9 hours that you have time for eating. And people who do that, and this is evidence-based again, they lose weight. And I know that there is a lot of data that's all over the place. It's going to be there because unless we have really large population studies of people doing this, it's going to be hard to prove one way or the other.
Absolutely. I think intermittent fasting, apart from time restricted eating, for me personally, what it did was appetite correction. Because if you don't eat for 18 hours, or sometimes I used to do 24 and all, your stomach shrinks. Your stomach is a smooth muscle organ, so it shrinks. And then when you go to eat, you cannot overeat. Therefore, it kind of helps with feeling satiated, and therefore you eat better. In that 4 hours or 6 hours or 8 hours of time you're eating, if you go dump cookies and cakes and pizzas and burgers and pasta and all this thing, then you have undone everything you have done. You're just damaging your body even more. And that is the problem. You have to have mindfulness approach to eating. You cannot, your body is your temple. Sometimes I tell my male patients who are into cars, think of it as a Lamborghini. You won't take diesel and dump diesel into your Lamborghini, right?
Right.
Why do you think it's okay to put crappy food into your body and expect it to function, take off like a Lamborghini? And Rana, my husband, he's a bariatric surgeon. And some days he'll be back home early, and I'm like, "Hey, what happened?" He's like, "Oh yeah, the last case got cancelled." I'm like, "Why? What happened?" He's like, "The patient's liver was too big, so we have admitted the patient to put them on a fasting for 48 hours, which will shrink their liver, and then we will reattempt it again." So, we've been doing it in medicine for different purposes for centuries. And India probably has the most, for religious reasons, but there was value to it. I'm not going to eat beyond 7 o'clock or 6 o'clock, or Thursdays I'm fasting, Mondays I'm fasting. Multiple religions, Muslims have been doing it during the Ramzan season, etc. But what matters is what you eat in your duration of eating. That I think is the key to the whole. So anything can be misused, right? E equals MC squared was a magical creation, and it was used for positive things and for negative things. It's
talk about Rana. We for bariatric surgery is like something I talk about all the time with my patients. You have people whose BMIs are 50s and 60s and 70s and 80s. We see that, and how can you tell them to do a Mediterranean lifestyle? I mean, how much are they going to lose? It's just a point of no return at that point. And those are the patients that I'm like, "Ma'am or sir, I mean, you are 35, 40. You already have stage 2 disease on a biopsy or whatever I did on them." Because those people typically, I need a biopsy. It's all these FibroScan and other ways of diagnosing them don't work. And I'm like, we need to do something now. And the only thing that typically works at that stage is bariatric surgery. Because that's the thing that you're going to just have a small stomach, like you said, shrinking stomach by intermittent fasting. Here you have a small stomach, done by a surgeon, and you just can't eat more, and that is the only thing that works. So I actually send quite a few patients for bariatric surgery because there's nothing else I can do for those patients. Otherwise, they're going to end up with end-stage liver disease. And guess what? If you have a BMI of more than 40, you're not candidate for a transplant. There's a risk, there's another contraindication, meaning that you have to have a certain, you might think everybody can get a liver transplant because from fatty liver. No, you can't. There are things you meet. If you have your BMI is too high, not a candidate. Doesn't matter how sick you are. So there's all these nuances that is, people, of course, my field is what we do, and it's a complex field, but they don't, when you tell them that, they're like, "Oh my God, if I don't make a change, that's it. I can't see my grandkids. I mean, something has to change, kind of thing." So yeah, important points.
So I'm going to ask you this, and this is a hot topic. It's become a money-making topic again. It's for weight loss, and I'm talking about fecal transplantation.
Oh, yeah.
Can you give us an insight about it? What is it used for? Is it valid, not valid?
I think there's a big role. The microbiome in the end, I'm sure even in cardiovascular disease, but in the liver disease, we know that the microbiome plays a huge role. Your bacteria, basically, for the audience, the bacteria that you have in your gut, right? I mean, your small intestine, play a huge role in your immune system, play a huge role in everything that happens in your body. So we know from this infection that people may or may not be familiar with called C. diff, which is an infection, a gut infection that you can get if you are put on antibiotics, and sometimes the body produces this bacteria called Clostridium, which then causes really severe symptoms. So there are, of course, antibiotics to treat that too. But there are people who don't respond to antibiotics, and now we have this fecal transplant, which is basically a stool from a healthy person's body, which has all those bacteria from that person that you take to basically cleanse out your bad bacteria and to replace your bacteria with that person's bacteria. And it works. Okay. So clearly your microbiome, your bacteria have to play a role in everything. And the gut and the liver are all interconnected. So all the bacteria that, unfortunately, that can cause liver problems when you are at that last stage, they come from the gut because of the cells that are supposed to be like close to each other. Now they have more space, and there's things that enter the bacteria that enters the liver and causes problems. So I do believe that our field is going in that route. In fact, there is going to be a role that's being studied right now, the role of fecal transplants and in even non-alcoholic fatty liver. not so much for alcohol, but for non-alcoholic fatty liver disease, is being researched. It's just very, very in its early stage, infant stages. I feel we need a lot more information about which bacteria, what kind, what do we need to replace, which are the harmful ones, to really say, okay, I'm going to use this as a means of treating your liver disease versus putting you on, weight loss medications or bariatric surgery or whatever, because that has a role. Now, how much of that role? I don't know. Time will tell us, how much.
So, Modi, we have taken you from the role of a hepatologist now into more of a gastroenterologist, and I'm going to ask you more gut-related questions.
Sure.
We talked about fecal transplantation. The next I want to talk about is small bowel overgrowth, or there is a SIBO, small intestine bacterial
Overgrowth. Yes.
Can you tell me about this and how that plays a role in liver disease, obesity?
So I just want the audience to know that Arasi and I hadn't discussed these topics before, so I'm extremely glad she's bringing this up for the audience, because what I'll tell you stories that are one of the biggest symptoms that gastroenterologists deal with, and sometimes they come to me and they know I'm a gastroenterologist, is bloating. Okay, I feel bloated. I feel like crap. I can't eat. I feel full very fast. And very overlooked is what you just mentioned, SIBO, which is small intestinal bacterial overgrowth, for various reasons. One of the common reasons is, of course, diabetes, because as you know, diabetes affects the nerves. The movement of your food through your entire intestine, stomach, everything slows down. So now you have bacteria that sit there. So again, I use the analogy of water that you keep outside of your home. If you leave that water without any movement, for a while, what's going to happen? You're going to have algae grow in that water, bacteria grow in that water. Same exact principle in the body. When you have food that stays in the gut, any part of the gut, for a longer period of time, bacteria are going to grow, because bacteria destroy that food. That's what they do, and you're going to have excess bacteria grow more than normal. What do bacteria produce? They produce gas, right? And when you have all that excess gas, you're going to bloat up. So it's a huge deal when the whole concept of small intestinal bacterial overgrowth, again coming back to the microbiome, is a huge problem. So I'm glad you asked me that question, because it's one of the most common reasons for GI visits for patients, IBS, irritable bowel syndrome, again, bowel disease, that people go to GIs for treatment. So yes, SIBO has a big role. Now, how does SIBO actually affect liver disease? We don't know that yet. There's probably some connection, but the connection is not been made yet.
What is the treatment for SIBO?
Oh, it's again, we have treatment. Again, and we come back to, it's not like we can do a fecal transplant for the patient, right? I mean, we're not at that level. But there is treatment, there is antibiotics that you can use. One of the most common ones that we are very familiar with. It's a common antibiotic, cephalosporin with metronidazole. Again for the audience, it's a very commonly prescribed antibiotic, been around for many, many years. It may or may not work. One time, typically we give it for 10 days. It may improve symptoms for a little bit, and they might need recurrent treatments of that for actually completely getting rid of it. I have an amazing example of a patient who had SIBO, undiagnosed for years. I was a fellow at the NIH training to be a liver doctor. And she came to me for, of course, liver disease, but then she told me about this bloating. And I'm like, I think you have SIBO. So I made her do this hydrogen breath test, where they measure the amount of hydrogen in your breath that's produced by the bacteria, right? So that's one of the tests that we used to diagnose. She came back positive. I put her on, and just to FYI, this patient had basically lost so much weight that she was given a feeding tube because she was getting malnourished. Yeah, she reached that point of, it was so bad. So she came to me and I'm like, I'm going to test you for it. We treated her for it. You won't believe it. This patient's feeding tube came out. Okay, I'll never forget this. It's giving me goosebumps talking about it. And unfortunately, she started eating so much that she started becoming overweight. I'm like, Mom, what are you doing? You need to really stop doing this. You've gone from getting a feeding tube to now going a BMI of, whatever I don't remember what her BMI was, but she had gained weight. My point is, antibiotics work. Not in everybody, but they work in a subset of patients. We can reuse that. You, of course, have this medication called rifaximin, which is a non-systemically absorbed antibiotic, which works mainly on the gut and also can work in those patients. So there is treatment. You just need, your first step is diagnosing it appropriately. That is where the problem is.
So the symptoms are bloating. I mean, is any other GI distress like diarrhea, constipation? Does that have
not necessarily diarrhea, constipation, because that could lead you to an entire different diagnosis, which is IBS. Irritable bowel syndrome, which affects a lot of people. But it's mainly bloating. They feel full very fast because it's all bloated, so they don't want to eat more. Which is why typically they can start losing weight, and they have a lot of belching. So it's either gas from the top or gas from the bottom. So those are the typical symptoms. And of course, they're very uncomfortable. I mean, when you eat and you're bloated, you feel yucky. That's what they say. I just feel sick to my stomach. I don't feel good. Like I don't want to eat. I just feel nauseous. Of course, all those symptoms that come with it. But diarrhea, constipation, not typical with that.
And what is the test? You talked about the hydrogen breath test. Are there any other tests you can do?
That's the main one. I mean, a lot of times I don't even order the hydrogen breath test. I do a complete history, and I'm like suspected bacterial overgrowth, and then at that point I'm saying I'm going to treat you. If you respond, I know it's the bacterial overgrowth, and you're done. Why worry about getting a hydrogen breath test? But the hydrogen breath test, it's easily available. You can order it anywhere, and it's been around for many years and get that. But that's the only test to diagnose bacterial overgrowth.
Fantastic. Modi, I think thank you so much for taking time. I think we had a great conversation. We talked about fatty liver from just non-alcoholic, then alcoholic. We talked about cirrhosis and end-stage liver disease symptoms. We talked about a topic which scared me the most was the acute alcoholic hepatitis. I think that definitely scared me the most here. And kind of segued into fecal transplantation and then segued into small intestinal bacterial overgrowth. Thank you so much. I enjoyed myself and I've learned so much from this. I hope it has been useful for the audience as well.
Oh, thank you, Arasi. This is fun. I enjoy this. Thank you so much for inviting me on your podcast. And all the best.
All right, good. Done. Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.